Hello, everyone. I'm Andrea Durst. I'm a member of the NIMAC leadership team. You are currently in the Resources and Genetics Practice Models for Rural Health concurrent session. So if you meant to actually be in the other session, please go back to your online meeting page and click Zoom Room A, but we're excited to have you here joining us today. And I'm really excited to introduce the speakers for this session. We've got a really great lineup for you for this session. So first, we will hear from Dr. Marc Williams, who is a professor and director emeritus for Geisinger's Department of Genomic Health. He's a clinical geneticist and research scientist who has worked for over 30 years in integrated healthcare delivery systems, serving rural populations. Second, we'll hear from Rhonda Jackson, who is a public health advisor with HRSA Region 3 in the Office of Intergovernmental and External Affairs. Rhonda has a broad knowledge of HRSA programs and has worked with grantees and community partners to support the development and improvement of healthcare systems. And the third member of our panel is Doson Nguyen. He's the Legislative Affairs Manager and National Rural Health for the National Rural Health Association. He represents the rural healthcare policy and programmatic interests of NRHA, with the U.S. Congress. So those are our speakers. Before we get started, we have a couple of poll questions to just learn a little bit more about you all who are here in the breakout session with us today. So these are questions that you may have already seen in previous sessions, but we like to know just who has decided to join us in this concurrent session. So if you want to put that poll up, excellent. Just give a couple of seconds to answer this one. All right, so we've got people from most of the groups. We've got some family advocates, community health workers, physicians and residents, and many genetic counselors and genetic counseling students. So hi, everyone, and welcome. And we've got then one additional poll. All right, so this one is asking about what your awareness is of the HRSA regional offices. All right, we've had a couple of seconds to fill out that poll. Do we want to go ahead and pull up those results? All right, so got some people aware of the regional HRSA offices and but many not. So it looks like we're going to be learning a lot in this session. So thanks everyone for filling those out. And I believe those were our only two polls.
There is a third poll.
Oh, there is a third poll.
We were maybe going to do it later though, but if you want to do it now, we can do it now.
Nope, we can do it later. That's what I thought.
That's for later. Yeah. Okay.
Okay. All right. So I'm going to turn it over to you, Dr. Williams.
Great. Thank you very much. Really appreciate the opportunity to be here with you today and talk a little bit about some innovations in genetic service delivery focusing on rural areas. I have no commercial conflicts, but I am presenting some information that is funded through some NIH grants listed there. This is a particularly relevant topic for me because I grew up in a rural area. I grew up in a town of central Wisconsin of 2,000 people. So I directly experienced the challenges of receiving healthcare in a rural setting, but this is even exacerbated with genetics. And here are a workforce survey from 2019 looking at medical geneticists. And you can see how the western half of the country in particular, and the aspects of the southeast and northeast are really without any sort of medical genetic services whatsoever. And a similar study from 2021 with genetic counselors has shown the same thing, where the center of the country and rural areas tend to have much less access to genetics professionals. Now, my career has been somewhat atypical in that I've never really worked at an academic medical center, although Geisinger did buy a medical school, so not technically we're an academic medical center, but they had to buy a medical school to get me. But I have worked in 3 large integrated healthcare delivery systems in Wisconsin, Utah, and Pennsylvania, all of which have very large rural service areas. So Gunderson Health System is located in La Crosse, Wisconsin, which is a metropolitan area of about 50 to 60,000. And we cover 3 states, southeastern Minnesota, southwestern northeastern Iowa, and southwestern Wisconsin. Intermountain Healthcare is located in Salt Lake City, which is a large metropolitan area, but has service throughout the state of Utah and into Idaho, most of which is very rural. And then Geisinger, where I currently work, is located in Danville, Pennsylvania, a town of 8,000 people where 14,000 people come to work every day in the large medical center, but we have a huge regional rural service network to deliver care. The largest population center in our entire service area is the Wilkes-Barre-Scranton area, which is under 100,000. So I have a lot of personal experience with this. And as I began to think about different service models, one model that I encountered early on are outreach clinics. And so I did general pediatrics for 10 years before I went back and did training in genetics. And one of the reasons, beyond the fact that I married a genetic counselor, that I decided to become interested in genetics was I worked with the outreach clinic from the University of Wisconsin-Madison that came to La Crosse, Wisconsin 4 to 6 times a year to see individuals with genetic conditions. And by working with them, I realized there was a real opportunity there and ultimately went back and pursued training. And when I was in Utah, I actually ran an outreach clinic up into northern Utah and Logan. And so one model of delivering care to rural services is this sort of, let's move the geneticist or the genetic counselor to different areas. It does work, it does expand the reach, but as you can imagine, it doesn't really solve the problem that we have inadequate numbers of care providers. And then I also wanted to mention that in Pennsylvania, some of you may be aware of this the Clinic for Special Children, initially based in Lancaster, but now with a second setting in Stroudsburg, which was done in conjunction with the Old Order Amish to basically provide care with genetics, pediatrics, developmental pediatrics, and laboratory services for individuals with genetic conditions. And this has been a really effective community partnership. But again, that model has been limited to southern Pennsylvania. It's really not been expanded much to other areas. Now, the pandemic, I don't have to tell this group, was a major disruptor. And one of the things that was realized during the pandemic was that telemedicine could be a huge opportunity to distribute services. Well, we in genetics looked at that and said, duh, we've known this for 20 years. The very first paper on telegenetics was published in 2005 by the group in Maine, which did some beautiful work about how to deliver services in their very rural state, where it's very difficult to get from the southern part of Maine to the northern part of Maine. And then in 2012, so again, over 10 years ago, we'd already had a systematic review of telemedicine and genetic services that was able to draw several conclusions. A lot of benefits, very high acceptability for patients and clinicians. Cost efficiency was improved. We have much reduced travel time and convenience for the individuals that are receiving services, as well as reduced wait times. The knowledge that was transmitted and the psychosocial outcomes were comparable to in-person encounters. And in general, technical issues were not a problem, although for those of us that spend their lives on Zoom now, we know that that's not always the case. But there were some limitations. There were a small number of minority patients that said that their psychosocial needs were really not adequately met through this telemedicine approach. And the providers, geneticists and genetic counselors, noted that it is more difficult to establish rapport and read nonverbal cues in these types of encounters. But in general, the conclusion was that the benefits, particularly the access benefits, far outweighed the limitations. Now, I want to introduce an economic concept here called scarcity, which is the basic economics problem that we have a big gap between limited resources and theoretically limitless wants. And I want to put forward an axiom, and I don't think this is going to be particularly controversial because I've heard lots of people that have stated this. There will never be enough genetics professionals to provide all the needed genetic care. So if we accept that as being true, then that means we're going to have to develop models that begin to provide genetic care that aren't solely in the purview of geneticists, genetic counselors, advanced practice nurses, and physicians' assistants. We're going to have to figure out different ways to do it. And so for the remainder of my talk, I'm going to give a very rapid and very high-level overview of several different approaches to this. So this is not going to be something where you're going to learn about anything in depth, but hopefully there'll be one or two things in this next portion of the talk that will be intriguing enough that you'll be interested in doing more research. The first thing I wanted to talk about was a group that was convened during the first round of funding through the Clinical Genome Resource, or ClinGen. And this is the Consent and Disclosure Recommendations, or CADRE, working group. And this was designed to basically say, well, do we really need a one-size-fits-all approach where everybody that gets a genetic service goes through traditional genetic counseling with, an hour to an hour and a half visit and 3-generation family history and intensive consenting and all those sort of things? Or are there certain aspects of genetic care that really could be done in novel ways? And what they found is that they, through the use of a number of engagement techniques and qualitative methods and Delphi methodologies, they were able to come up with different types of genetic services, some of which required traditional genetic counseling, those that involved increased complexity of decision making, were a medically burdensome condition. If there was uncertainty around whether a gene and disease were really associated with one another, or there was evidence of adverse psychological outcomes, so like with Huntington's disease or things of that nature. A traditional genetic counseling model would be needed for those, but that was a relatively small percentage of the overall range of genetic services. And it was really found that there were other services that had decreased complexity, testing for known familial variants or a known variant that has very well-established disease validity and good information, and that there are quality education materials that are available. We found that for those types of encounters, using much less intense encounters with professionals that weren't necessarily fully trained genetics professionals actually had very equivalent outcomes to traditional genetic counseling. So this was one attempt to say, how can we not treat everything the same, but kind of make objective decisions about what needs a traditional model versus alternative communication. That then led to using more sophisticated technology to say, how could we utilize advanced technology to perhaps more replicate this encounter? So individuals at Geisinger that were in the Impact FH project, part of that project was to develop a chat bot called GIA, the Genetic Information Assistant, who would work with individuals to prepare for genetic testing, obtain consent, and in some cases for negative results, transmit those results, and also facilitate cascade testing for at-risk family members. And what we found is that chatbots can in fact facilitate familial communications about hereditary conditions, so we're not as dependent on the proband where we say, here's the information, you can give this to your family members and good luck with that. But we can use this chatbot technology through smartphones to be able to distribute the information better. Interestingly, while we anticipated that more people would prefer to use smartphones for this, most preferred to receive the chatbot information through the electronic health record portal. So they were within their healthcare setting, their virtual healthcare setting. Again, perhaps not surprisingly, older individuals tended to opt out of the chatbot communications more frequently. And then we also noted that if we provided reminders and additional touch points, both with the team and with the technology, that improved chatbot engagement. Now, another study that we've been looking at is the collaborative approach to reach everyone with familial hypercholesterolemia. So familial hypercholesterolemia is a genetic condition that results in elevated LDL cholesterol and increased risk for early heart attack and stroke. And we know that this is dramatically under-recognized. There are effective treatments for individuals that are identified. So it's very important to identify these individuals and initiate treatment. But again, using a genetics model really doesn't allow us to get at these folks. And so this approach was to develop a comprehensive education and training approach to primary care clinicians, and then to provide tools within the electronic health record that would support the primary care clinicians to identify individuals and initiate treatment or referral for individuals who are identified with familial hypercholesterolemia, and then testing that in a pragmatic hybrid randomized trial. And so we're in the middle of doing this now. This is the overall schema here, where we've identified a population that we want to have diagnostic evaluation, and then we use outreach to patients. We have clinician education training, and then we use standardized documentation within the system, including lipid calculators and smart sets and problem lists, et cetera, that can make sure that we're consistently documenting the presence of these disorders. And then we basically, as we deploy these things, we learn. We know that something that I always say when we're rolling out a new technology is that we guarantee it's wrong or your money back. But the second part of the guarantee is we guarantee we will fix it. And so one of the things we do in this hybrid effectiveness trial is to continually improve the intervention based on feedback from patients and clinicians. And I'm not going to go through this in great detail, but you can see here that we have both clinician notification and patient letters or messages through the electronic health record that are going out. And you can see here that while the numbers are still relatively small, we are diagnosing individuals with FH. People are using the tools. We've identified a number of people with new lipid disorders and referrals to lipid clinics and initiation, importantly, of lipid-lowering medications. So we are seeing signals that this intervention is improving care, although we still have a long ways to go. The other thing that was interesting here is that when we talked about this, there is a recommendation from the American Academy of Pediatrics that talks about how we should be doing universal lipid screening in pediatric patients. And our system wasn't doing that. In fact, most systems aren't doing it. And so an unintended consequence of this was that in response to this study, which included pediatric patients, the pediatric department said, we are going to set up a quality improvement initiative so that the recommended lipid screening is done with all children. So this was not part of the project, but sometimes we get improvements in places that we don't expect. And lastly, I just want to give you a very quick view of a project that I'm leading where we're imagining a future state where everybody has already had genetic sequencing and it's available in the electronic health record. If we have that, what could we do with that information? And one of the things we've envisioned is that we can actually look at electronic health record data, identify individuals that we think might have a genetic condition based on information that's presented there. We can go to the sequence and essentially order a genetic test in silico, analyzing the genes that are known to be associated with that genetic disorder. And if we find a causal variant, return that result to the clinician and initiate care. Obviously, there's a lot of pieces that go into making this successful, not the least of which is we're going to be giving a diagnosis, or at least a potential diagnosis, to a clinician who didn't even know that they ordered a genetic test. But that's important because we know that very often individuals with genetic conditions are not identified because no one thinks to actually order the test. So we're in the process of testing this out now, and we have built some shots about how this might work. This would be an alert that would pop up to say, hey, we think this individual might have autosomal dominant polycystic kidney disease based on bilateral cysts and a family history. Here are some recommendations. Do you want to add that to the problem list? Do you want to order confirmatory testing or do a genetic counseling referral? They may open the disease manager, in which case they'd get more detailed recommendations about what potentially to do. And you'll notice in the lower left here, for more information about autosomal dominant polycystic kidney disease, we would have a very brief summary, which we know clinicians like, that 10 to 15 second knowledge burst at the point of care just in time, with links to additional resources as needed. So in conclusion, we need continued investment to grow the genetics workforce and improve its distribution, but that's not going to be sufficient to meet all the needs. And so we need to begin to look at clinician and patient-facing tools to make sure that genomic-informed care is available everywhere. Genetics experts have to be available as the knowledge resource to create the guidelines and best practices to support this care. And then we have to use informatics intelligently to improve access. But I think it goes without saying, in rural settings, we also have to understand that there is a digital divide, that many rural areas don't have access to the type of information systems that are needed to support this vision. The goal ultimately is that genomic medicine is simply medicine. Thank you very much.
All right, thank you, Dr. Williams. We should have some time at the end for Q&A, so we're going to move right on to our second speaker. Rhonda, if you wanted to share your slides.
Absolutely. Hopefully you can see my slides. If not, give me a thumbs down. Okay, you can see them. Okay, great. Good afternoon. Good morning, still good morning, and thank you for having me. Shifting gears just slightly, definitely appreciating the information that was just shared. I will be talking this morning about HRSA resources for rural health. And so I am based in the Philadelphia region office. We call that Region 3. I'm going to talk a little bit more about regional offices and their role, and then just some resources that we may have available that are maybe of interest. So I have no financial disclosures to make. And so I wanted to talk a little bit about who we serve within HRSA. Across the country, we're serving approximately 30 million patients. These numbers have even changed since I've submitted this slide deck. I think this was much based on data from 2022 and early 2023. And so these numbers continue to evolve, but you can see just through this slide, the broad scope in terms of representing and serving maternal populations, serving infants, and then serving and touching and interacting with more than 1,900 rural counties across the U.S. So we're really looking and serving just populations across the whole country, which is really the focus of our program, to provide and make sure that there is access to care for those that need it. In terms of thinking about the focus of HRSA overall, certainly there are some key areas that we're working in, definitely providing, as it says, healthcare to underserved and rural communities, the health workforce, We can't mention this enough. We hear it in many conversations. Maternal mortality as it exists, and then also rural health and behavioral health. So these are definitely key areas in which HRSA is working. Our current administrator, you'll see, has identified these as some priority areas related to substance use and mental health, health workforce, and maternal health. And you may be saying, well, I don't see genetics in there, but we know that those topics affect all of these populations, whether it's the workforce as it relates to it, whether it's services to mothers and expected parents. So certainly embedded in all of our work. If you don't see a particular topic that you're working in, I'm sure that it certainly rolls up into one of these key areas in which we work. So at the top of the session, there was a poll that asked if you knew how many knew about HRSA, had interacted with HRSA, knew whether or not there were regional offices. And I think I recall seeing maybe about 67% or so that said they didn't know there was a HRSA regional office. So I'm glad to be here to share more information about that. Many may be familiar with our offices located down in our headquarters is in Rockville, Maryland, but we're also excited to share that we do have 10 regional offices around the country and a sub office in Puerto Rico, particularly, and that coordinates with the HHS offices that are around the country as well. And so I am based in the Philadelphia office that covers the mid-Atlantic states of DC, Delaware, Maryland, Virginia, West Virginia, Pennsylvania. I went out of alphabetical order there. And then we also have our New York regional office that also is serving New York and New Jersey, as well as Puerto Rico, and then the Virgin Islands. And so between our two offices, we cover regions that you may be working in and can be a local point of contact. The New York regional office is based in New York City, but similar to myself, we're all able to and often are eager to go out and meet, and as you can see from the pictures here, engage with our partners all around the area. So I did just want to highlight a few key programs that HRSA does support and fund. And the reason I'm mentioning these is because as you think about your work and potential partners that you could engage with, these may be programs that you're already familiar with or might want to know more about as we go forward. One being the Health Center Program. Federally Qualified Health Centers is often the name that we've heard about as it relates to that. And this program has existed for many years to really support and improve the health of the nation's underserved communities. And they provide access to high quality primary health care, often including specialty service when available. And they also offer comprehensive care. It's not just primary care, it's medical, oral, mental health, substance use treatment, other specialty services that are provided, telehealth. And so there's approximately 1,400 across the country. You can see on this map the high concentration in our area, which includes rural and urban areas. So wanted to highlight that program as well. Okay. The next program that I wanted to highlight was surely maternal and child health. We have a maternal and child health bureau that serves as you may already be familiar with, the needs of women and children and their families. And so we're serving through block grants to states that program. We have visiting programs that go into homes, as well as programs that are focused on addressing prenatal priorities. And so we just want to highlight these programs are also across the country. They target rural and urban areas. And so this may be an area where you're intersecting and learning more about the work and the partners that are working in this space. As we talk about that, we always do. I know we're talking about genetics today, but also want to highlight our National Maternal Mental Health Hotline, TLC Mama. And so you can certainly scan this. And we launched this in May 2022. And since that time, I've had over 23,000 conversations by phone and text. It's available 24 hours, 7 days a week, 365 days a year, and it's really referrals for pregnant or postpartum mothers facing mental health challenges and their loved ones. Services and support are provided by professional counselors and staff in English and Spanish and voice and text, and as well as interpreter services in 60 other languages. So if you're looking for a resource for partners or patients that you may be working with, please do feel free to use this. There's promotional materials available in different languages, and just a great resource to have as you're working with maternal populations. I did also want to share about our Federal Office of Rural Health Policy. acronym FORHP, as it's here. And so the Federal Office of Rural Health Policy, also serves and has a focus on providing support to rural communities across the country. They invest a significant amount of funds each year to serve across the country critical access hospitals, rural health clinics, community-based hospitals, really with the goal of ensuring access to care and supporting those healthcare systems. As you can see from this slide, there are approximately 200 grantees and that are in place, and variety of rural health initiatives that are supported with these funds. And so I would highly encourage you, if you haven't had a chance to learn more about the Federal Office of Rural Health Policy, to take a look at the website for HRSA and specifically the Federal Office of Rural Health Policy to see the list of programs, the exhaustive list of programs that they offer. I did just also want to highlight work that's being done, particularly with the Rural Maternity Obstetrics and Management Strategies Program. This initiative started in 2019, as you can see, and is continuing through, has continued through fiscal year 2023, and hopefully will continue to go forward, but really works with improving maternal outcomes in rural communities. So as you think about your work and networks to connect with, this may be of interest to you. And so we're very proud of this program and all the outreach and the consortiums that have been developed. And so just wanted to highlight it as another potential resource. And then weekly announcements that are coming out of the Federal Office of Rural Health Policy. If you want to know what type of policies, what type of activities we are currently engaged in, you surely can find that information by going to HRSA.gov and our email subscriptions to be included in our newsletter. So a couple of last things that I did want to highlight was just some resources, as I know there's interest with that. And so this one is the Rural Health Information Services Hub. And I highly encourage you, it's RHI ruralhealthinfo.org. And the reason I have this here is they have topic guides, they have funding opportunities, models, and innovations. They can help if you're looking for models of programs to implement, want to know maybe perhaps people that have done information or done programs in certain areas. You can certainly use this as a resource to research and find some of that information. So please do, if you have not had a chance to visit that, do that. And then in addition to the Rural Health Information Hub, the Rural Research Gateway, that also houses information about funding models, research models and information. And both of these tools you can reach out to. They can help you with research. Perhaps you're looking for articles or information in a specific area. They can help to highlight that information and do some of that legwork as well. And I think I had one other poll that maybe if we have a second, we can pop that up now. You know where to find information about HRSA programs and current grantees. I'm going to talk about a couple more resources and just see if you have an idea of where you would go if you wanted to know about those things.
Yeah, it looks like that poll is up.
Okay, great. Okay. And we can, so I'll continue to talk through that, but just so you know, we also have an Office of Telehealth while you're filling out that poll that just addresses all things telehealth. It's a great resource for models. We have a Mid-Atlantic Telehealth Resource Center. I know that will be presenting later this afternoon. So I'm sure they'll be able to share much more about what they're doing in that space as well. And I want to encourage you to do that. They reach out, their work is offered at minimal to no cost, most often no cost. So I would highly encourage you to connect with your telehealth resource center if you haven't done so. And I see that most of you do know where to find out information about HRSA programs and grantees, but a large amount of you that don't. So hopefully you'll be able to do that after this session. And then just rounding out HRSA funding opportunities. You can always find our funding opportunities on our grants page, our HRSA page, by just using the drop-down menu for grants. We have lots of technical assistance resources, and particularly I want to highlight data.hrsa.gov. And the reason I want to highlight that particularly is because that's where you can find out who has current grants, what programs have been awarded in the past. There's lots of data and dashboards that are available on that website. And then lastly, just to share, when would you want to contact HRSA the Office of Intergovernmental and External Affairs? Our office when you want to know more about programs or initiatives, when you need more information, when you're trying to connect with a partner, our job is really to be that HRSA ambassador and liaison to connect, to help build those partnerships. So as you continue in your work, I'm certainly looking for how we can support you. Feel free to reach out to your HRSA office, your regional office at any time. A few key websites I've included here so that you can see those, from HRSA to grants to our data warehouse will be in the slide deck, as you can see that. And then if you do have want to reach out to your regional office, these are our contact information, Captain Shandi Ghosh in New York, and then myself for the Philadelphia area. And we'd be happy to follow up and share more information with you about our offices and programs and things that we're engaged in. So please do connect with us, sign up for our weekly updates. We provide a wealth of information every week. I read them, they're informative to me, and hopefully they'll be as equally informative to you if you'd like to sign up for our biweekly e-news newsletter. So having said that, I think I was able to squeeze it all in. So I'm going to see if I can stop my share
Right in
now.
time, Rhonda. Thank you so much. Again, we're going to save questions for the end, but feel free to put them in the chat as you think of them as our presenters are speaking. So we're going to move on to our third presenter. So Doson, if you are ready to share your slides.
Okay, can you see them?
No, not yet. Oh, here we go.
All right. Well, hello, everybody. It's great to be in front of you today. Great to be able to have the opportunity to speak to you. I just wanted to make a little bit of a comment on Rhonda's presentation. Thank you, Rhonda, for showing us about what you do at HRSA. So many of the programs that we advocate for at NRHA through Congress, whether it be to appropriate funding or to authorize programs, these healthcare programs that really benefit rural America, a lot of them are administered through HRSA. So I just want to take a moment to say thank you for what you do and who you represent, because it really means a lot for so many rural Americans. So hello, everybody. My name is Doson Nguyen. I manage legislative affairs at the National Rural Health Association. And NRHA is a national nonprofit. We have 21,000 members across about 47 states now. Our membership consists of nurses, physicians, hospital CEOs, and private individuals as well. And the mission is to educate and advocate for equality of rural healthcare. So many of the things that rural hospitals and rural healthcare providers and rural patients have to deal with are completely unique compared to their urban counterparts. So what do we fight for on behalf of rural? So we have about three pillars that we focus on. Number one is investing in a strong safety net. So since 2010, and this stat here says 160, but it's already changed. 170 rural hospitals have closed their doors. And about 50%, a little bit more than 50% of them are operating in the red margins, which means they're operating with negative margins and they're very likely to close soon. That's an issue for so many people in rural areas that need not only general care, but specialty care as well. And I'll address that a little bit more later. Another one of our pillars is, of course, so important is to make sure that we maintain a robust rural health workforce, whether it be physicians, allied health professionals, or even sometimes kitchen staff. I was speaking with a hospital CEO recently who said that he was having a difficult time not just trying to find allied health professionals like medical assistants and CNAs, but he was having a difficult time even staffing the hospital kitchen workers. And we all know that every single part of the hospital, every role is important. And so maintaining a robust rural health care workforce in every aspect is important. Rural health equity as well. I think it's really difficult for many rural hospitals because they have the same overhead, they have the same staffing issues, they have the same costs, but their patient volumes are so much lower. You may have a rural health clinic that sees 4 or 5 patients a day, and the comparison of that is an urban hospital that might see 300 or 400 patients a day. So that volume, it really helps to keep urban hospitals afloat, whereas rural hospitals can sometimes struggle. Okay, so the rural context. So let's talk a little bit about the differences between rural and urban areas. Rural areas make up about 97% of the landmass in the USA. Oh, let me get this back here. And about 20% of the US is considered rural. So about 60 million Americans are considered rural. Every agency has a different definition of rural, right? The census defines rural differently. Federal Office of Rural Health Policy defines rural slightly differently. HRSA defines rural slightly differently. Because what exactly is rural, right? And so we try our best to try to be as representative as possible. But it is really important to sort of delineate what rural is, who is rural, who is represented by rural health policies, so that we can reach the right people. Yeah. This here is a little bit of a stat between rural and urban. Okay. Yeah, so accessing specialty care in rural America is much different than living in an urban area. You know, even for obstetrics services, I think there was something like 25% of OB services have closed within the last 4 or 5 years across the nation. And you know, obstetrics and gynecology is not really a specialty service, especially in the way that genetics care is. And so in order to address those sorts of challenges, part of what NRHA does is within our 21,000 person membership, we ask our membership, we say, hey, what are your challenges? And one member, we have a member in Utah. His son was born with renal agenesis, which means he was born without kidneys. And so he's 2 years old now. And throughout these last 2 years, he's constantly had to travel from rural Utah to make his appointments to get dialysis, to see a specialty care provider to diagnose and treat him. And so much of that family's life now is taking care of their 2-year-old son with renal agenesis, and they're traveling days at a time to go to different states. They're driving 4 or 5 hours to go to a specialty care clinic. And it's really difficult on them. And because you live in a rural area, it doesn't mean that you shouldn't be entitled to the same amount and same quality of care that so many people in urban areas are entitled to and are able to receive. And so much of what we do at NRHA is to be able to advocate for those people. And whether it be in legislation in Congress to establish more rural health clinics, or to put out to try to incentivize more specialists to stay in rural areas. And in fact, a lot of this is what we do with programs that we advocate for that end up trickling down through HRSA, who really are the ones that do the hard work of administrating the programs that promote care in rural areas. One of them is, for example, the Rural Residency Planning and Development Program. What that does is we acknowledge that physicians tend to stay where they do their residency. And so physicians in rural, there are about half as many physicians in rural areas proportionally as there are in urban areas. And so it's really important to incentivize primary care physicians, but also specialists to train in rural areas, because people tend to stay where they train. In fact, 60% of physicians who train in rural areas end up staying there. So if you complete a residency after medical school in a rural area, oftentimes you end up planting roots. You join the local community, you might join the local church, you might meet a partner, and you end up staying in the rural community. And that's what we want. We want to be able to have programs that incentivize providers to stay in rural areas so that they can provide the care that rural Americans need. And so many of the programs, in not just workforce, but our hospital stabilization programs and so on are administered through HRSA as well. So it was great to see Rhonda go through a lot of that earlier. Oh, yes. Okay. So telehealth models. This is obviously, thank you, Dr. Williams, as well for speaking about telehealth earlier. But in Congress right now, this is one of the biggest topics, top of mind for everybody. Everybody's talking about telehealth because realistically, it's a piece of innovation that is really helping so many people, especially in rural areas. And a lot of our work at NRHA now is to expand telehealth, allow audio only telehealth. Really, just let's use that. We have the technology. Let's use it in a way that is beneficial to everybody. Yeah. Rural health resources, a lot of these resources here, actually, Rhonda had shared. We use this very often, Rural Health Information Hub, and state offices of rural health as well. Okay, this is the point where I tell you how to be an advocate, or hopefully I can sort of motivate you to be an advocate for your issues. And so, I talked a little bit earlier about one of our members who has a child with renal agenesis, and it is his entire life now. He became president of our state association in Utah, our state rural health association, and that is part of what he does. Half the time he's taking care of his child. The other half of the time he's advocating for more specialty care services across America in rural areas. And so much of the work that he does, I went to Mitt Romney's office with him. I went to several congresspeople's offices with him. And what we did is he was able to tell his story. And he was able to say, hey, this is my personal story. This is what's happening with my child. This is what's happening with my family. And these are the things that the federal government can do in order to help me and people like me. Because if I'm experiencing it, so are potentially millions of other people. And I'm here to serve as a voice for them. And so that's what we do through advocacy. And I don't want to get into sort of the details of how to be an advocate on the Hill, but we do every year host an annual conference in Washington, D.C., where our membership comes from all over the nation to gather, usually about 500 of us, and we talk about what policies are important to us. We establish a policy agenda and we say, hey, this is what we want to advocate for on behalf of rural America. And we would love to have more voices, especially in the genetics field and in specialty care. Okay, so here's some more resources. All of these links here, well, I think when the slides are shared, we'll link to the NRHA website. We have a legislative tracker here. So whatever issues are important to your area, to your interests. We've endorsed 170 pieces of legislation this year because rural healthcare is healthcare. People get heart disease, diabetes, in fact, more so in rural areas than they do in urban areas. Yeah, so you're welcome to take a look at these advocacy resources here. If you have any questions, if you'd like to join NRHA, if you'd like to know more about how to advocate for the policies and programs that are important to you, go ahead and reach out to any one of us here. Thank you.
All right. Excuse me. Thank you so much, Doson. So now we have about 12 minutes for Q&A. I haven't seen any questions in the chat yet, but if you have questions for our speakers, please feel free to put them in the chat or just unmute and ask them live. Oh, here we go. So our first question is from Emily, and she asks, is there any national movement to facilitate telehealth access across state lines? During the pandemic, she provided telehealth to West Virginia, but after West Virginia closed her privileges, however, those privileges did in fact increase access for rural West Virginia patients.
Yeah, I'll take a stab at that. So there is federal legislation for advancing of telehealth, making sure everybody gets broadband. There's several pieces. I wouldn't go into specific details right now, but we also know that the states also control their own telehealth policies. I think maybe Dr. Williams or Rhonda might be able to speak more to.
Yeah, it is a challenge that gets even more complex than just the state licensure. So while we can have national health policies, licensure is maintained by the states, and there's no reciprocity for the most part between states. And then what's even more complex is that to practice medicine, you need to be affiliated with an institution where you are credentialed. And then same thing with insurance companies. You have to be credentialed with the insurance companies to get reimbursed. So there's all these different complexities that have to be organized to make this happen. All that being said, I think it is something that is really rife for an innovative solution that reduces some of these barriers that are essentially administrative. They have nothing to do with quality of care, but they have everything to do with reducing access.
And I'll just jump in and add, I know I talked briefly about our telehealth program, and our telehealth resource center will be speaking later today or this afternoon. But for example, one of the programs funded by HRSA is a licensed portability grant program that looks at creating those opportunities to work across state lines as well. And so I know that there have been several awards that have been funded through that program as well. So that's just one example of how HRSA is trying to also acknowledging what you said about the challenges with working across state lines.
Great, thank you. Other questions for our speakers?
I'll just tee up one additional aspect I think that's quite interesting when it comes, and this is something that affects all healthcare delivery, not just rural. But the other challenge that we have with coordinating care for individuals is that information right now is housed institutionally. So you go to Clinic A and they have all your records, and then you go to Clinic B, or sometimes even other parts of Clinic A, and they don't have access to your records. We don't have a patient-centric approach to health information. And this is particularly important for genetics, where a genetic test result, a germline genetic test result, is going to be relevant for your entire life. So we need to also think about how does information move with patients as they navigate through our complex healthcare delivery system.
Yeah, thanks for adding that, Mark. All right, we've got another question, a couple questions in the chat. So Mabel asks specifically of Rhonda. So I'll put this one to you first. Do you know if any of your programs such as Title V, Maternal and Child Health Block Grant, or Our Moms assist with offering genetic services for prenatal care?
Yes, so those programs are, the Block Grant is offered as a block grant to the state. So the services offered under that program may vary by the state that's administering it. So I couldn't give you a definitive answer, but I'm happy to follow up. If you have a specific state that you're interested in knowing about particularly, you could certainly reach out to me, and I'd be happy to follow up and see. And the same with the Our Moms programs. I'm happy to look up the grantees that may be of interest to you, to pose that question, or then help to make connections if possible. So please do feel free to follow up with me after if that helps. So sorry, I can't give you a definitive answer, but we're happy to find out more. Thank you.
Great, thank you, Rhonda. All right, our next question is directed at you, Dr. Williams. So do you see the great model you created being packaged for other areas, especially rural areas?
Well, we're definitely using standards to create our models, and we're deploying them in electronic health records that are certified. And without naming names, the electronic health record that we use is used by probably the majority of healthcare systems in the country. So I think there's at least the potential there. The issue often comes down to, though, whether systems are willing to deploy something off the shelf without customization, because at the end of the day, they're responsible for the care and the liability associated with that care. So in most situations, even when we do have something that is relatively reusable, there's usually some amount of customization that's done by the end user, which does tend to make it a little bit more difficult to just sort of deploy these things broadly. But there's a lot of different groups that are working on standardized approaches to this, because again, one-off solutions at the end of the day are not going to be particularly useful.
Mhm.
This is Luba. This is, I think, a question for Dr. Williams. I'm in upstate New York. We practice in a sort of a rural approach. You know, I think having a program like yours that has this institutional support, I think about these very small community hospitals that are trying to participate in genomic medicine as they define it. You know, I think there definitely needs to be more creative thinking about how to help these small rural hospitals. You know, they're lucky if it's a 50-bed hospital, but they still have a quote unquote cancer center and whatever. I think that there may be an opportunity looking forward. I'm not exactly sure exactly what's contributing to this, other than there's so many more genetic counseling programs now that are generating all these genetic counselors. Maybe we don't have as few genetic counselors to enter into rural community settings. And I'm not exactly know what the answer is, but we need to invite more genetic counselors to come into practice in community hospitals that may not have some sophisticated support like you have at Geisinger.
Yeah, but although I think that there's a different way to approach this, and if we look at the integrated systems that I described, the three that I've worked at, all three of these have a network of community hospitals and critical access hospitals that are part of our umbrella of care. In addition to that, we have relationships with hospitals that are not owned by the entity, but for which we provide support to build in electronic health records, to provide health information exchanges. And so for our MyCode program, which I didn't talk about today, about a third of the individuals that are in MyCode are receiving genetic results, and they're not Geisinger. They don't get their regular care through Geisinger. They're getting their regular care through non-Geisinger associated primary care physicians. And we've developed ways to provide the information and the support to those individuals. And so I do think that we don't have to, again, think about how can we get a genetic counselor to a 50-bed hospital. I think that's going to be something that, unless that person grew up in that town, it's highly unlikely they're going to be practicing there. But I do think as we have more consolidated and integrated models of care, that thinking about how we can extend those services, whether it's through a spoke and a hub, whether it's through outreach, whether it's through electronic means, is critical if we're going to actually be able to deliver that care. I just don't think that, the idea of an isolated community hospital in the middle of nowhere that's not affiliated with any other big system is ultimately going to be sustainable for the reasons that both Doson and Rhonda put forward.
I agree that a 50-bed hospital couldn't really wrap their brain around this. But I just think that there are these other sort of regions where you could have more collaboration and maybe have access to MyCode but somehow they have to be introduced to this idea. And I'm not sure who's introducing the CEOs to this idea, because really, how does this benefit their 1% profit margin and so on? So,
yeah, I think you put your finger on a very important point here, which we're in early days in genetics and genomics. And so the value proposition is still in the process of being defined. And we're going to have to do a better job of saying this is what this will bring to your organization before there's going to be consideration there. Some of you may have on the call may have heard me say this, but I say, we as a genetics profession are phenomenal evangelists. We say, you got to believe that what we do is really good and really important. But you know, as the saying goes, in God we trust, all others should bring data. It's time for us to bring some data.
Thank you.
And Andrea, is it okay if I add one quick comment as well?
Sure, absolutely.
I see in the chat, there were a couple of people that were asking about connecting with FQHCs to provide information. And so I just did want to highlight, certainly outreaching and connecting with your FQHCs can be helpful. Your HRSA regional office can help with that. In addition to that, we have primary care associations, which serve as a technical assistance and organizing body that provide technical assistance to the group of FQHCs that may be in a particular area. They do lots of conferences, training sessions, and also, so that may be another connection to make to begin to think about doing some outreach as well and education if that's an opportunity. And the regional offices can also help to connect you with those entities as well. So I just wanted to offer those two quick suggestions, and happy to talk more if you want to follow up. Thank you.
Yeah, that's great. Thank you, Rhonda. So we are at time. I know we have a couple of additional questions in the chat, so we will try to get those answered after the session, and potentially put those answers, I think, in the Google Doc that we've been keeping for the meeting. So it's time now for everyone to go back over to the main meeting site. Oh, Todd's put some things in the chat about how to save the chat if you're interested in doing that, and how to return to the main session. So we're going to have about 10 minutes in the main session to kind of hear from both concurrent sessions and to do some cross-pollination. So I will see you back in the main room. And thank you again to our amazing panel of speakers. We're so glad you were able to join us today.